Welcome everyone to our Diversity Forum session. Our session is titled Bridging the Gap, Addressing the Mental Health Needs of Underrepresented College Students through the Community Support Specialist role at UW-Madison. So in this talk, we will be talking briefly about introducing our clinic, our community support specialist role, our support work for the college students, and also at the end of the session, we will have an open dialogue for the audience to ask us questions about our role, about the clinic as well. Okay. Do we have the slide?
Give us a second here just to... There we go.
Okay. All right. Before we get to our presentation today, I want to take a moment for us to do a land acknowledgement. The University of Wisconsin-Madison occupies ancestral Ho-Chunk land, a place the nation has called Daejeop. In an 1832 treaty, the Ho-Chunk were forced to cede this territory. Decades of ethnic cleansing followed when both the federal and state governments repeatedly but unsuccessfully sought to forcibly remove the Ho-Chunk from Wisconsin. This history of colonization informs our shared value and future of collaboration and innovation. Today, UW-Madison respects the inherent sovereignty of the Ho-Chunk Nation, along with the 11 other First Nations of Wisconsin. However, we want to acknowledge that a land acknowledgement is an incomplete practice. A land acknowledgement should not be a substitute for solidarity and actions around Indigenous rights. If you are looking for extra educational resources about history of the First Nation and the Ho-Chunk Nations in Wisconsin, Indigenous rights effort, and Indigenous solidarity for Palestine, please check out the QR code we have on the screen. Thank you. Now I'm going to transition to Dr. Pahar to introduce our session and our team.
All right, thank you so much for joining us this afternoon. We're gonna, actually each of us will introduce ourselves in this space, and then we're gonna talk a little bit briefly about the model at the clinic, talking really through the partnership that we have with DDEA as well as the University Health Services, MHS, Mental Health Services, to really help address maybe this need for underrepresented students in regards to their mental health. So my name is Pahar. I am the clinic director this year, and so I have the great privilege to really work with these amazing graduate students who work with undergraduate students providing mental health resources. So I think as the director, part of my role is provide oversight, supervision of the students, and ensuring that they are providing ethically, culturally competent care to all of the clients at our clinic. And so I have been in this role. This is the first year for me as a director, but I've been the assistant director for the past 4 years. I'm also a graduate of UW-Madison from my undergrad, my master, my PhD, so I'm a fourth-time Badger. So I'm excited to sort of come back into this role as a clinical faculty in the Department of Counseling Psychology, and was a member of the CEO when I was in the TRIO program here at UW-Madison. So I'm very familiar with DDEA in that sense.
Hello? Okay. Hi, my name is Natalie Rivera. I'm a fourth-year doctoral candidate in the counseling psychology program, and I was in this role last year for a year. And now I'm one of the project assistants at the counseling psychology training clinic, so getting to maybe see this process and see how we care for students from different perspectives has been really cool. And yeah, I'm really happy to talk more about this role. It was really meaningful for me to get to connect with students in a different way, like outside of an individual therapy session. So I'm excited to talk more.
And then Kivon's not here, but Kivon was a community support specialist for 2 years. He has to teach right now, so he couldn't make it to the presentation. So a true community leader too. Something I think he'd want y'all to know is he's from California, coming to Wisconsin. Obviously there's demographic and cultural differences, and really being able to meet students where they're at and also hold space for their identities, being at PWIs has been important to his work too. So Kivon helped us with this presentation, so we wanted to acknowledge him in his space, even though he's not here with us right now. And then there's me. I'm Nasita, she, her pronouns. I am currently a community support specialist with the CPTC. I am a third-year doctoral student in counseling psychology, which just means I'm studying to be a psychologist right now. Like Dr. Her, I'm from Madison. I've been here since I was a kid. I went to undergrad here. I was a DDA scholar. I tell folks back in the day, I was a People's Scholar, left for a little bit and came back just because why I became a psychologist is recognizing how, I guess, hard it was for me to navigate a PWI and how culturally informed spaces really helped me, I guess, with my own mental health and academic journey, and then being able to do the same for students now feels really important to me. So this is like a little preview of why I pursued the role or came back to Madison for my PhD.
Hi, my name is Chi, and I use she, her pronouns. I am a Vietnamese international student at UW-Madison. So I got my master's degree in clinical and mental health counseling at Marquette Universities, and now I'm at UW-Madison to be a third-year doctoral student in our counseling psychology program. So I spent most of my time in the U.S., also around the Midwest area as well. Previously, I was a POSSE mentor with the POSSE program, and that was such a meaningful role for me, and it's really sparked my love to working with college students. And it's feel really helpful to think about what mental health looks like outside of the therapy room, but more integrated in the community. So now for this year, I'm being in this role. It feels meaningful to also be a part of the community, supporting the community, but also in a different role and different hats and expertise as well.
Okay, so for those of you who are probably familiar with the CPTC and the Counseling Psychology Training Clinic, you may not need to hear all this, but for folks who may be online or join us today that maybe are unfamiliar with the clinic, so we are the training clinic for the counseling psychology program here at UW-Madison. And in our department, we have both a master's and a PhD program. And so many of our students get their training, their first time, or maybe as advanced students, these students up here come back to the clinic to really get training, clinical training on how to actually work with clients at the clinic. And so the clinic has two missions, as you can see up here. There are twofold to it. One is we want to be able to provide affordable, high-quality, ethical care to clients, whether they're a student at the university or community member. And we do see both at our clinic. And as part of that affordability and access to mental health care, we used to be a sliding scale fee, which means that we work with the client to determine what amount they're able to pay for the services they receive at the clinic. Since the pandemic, we actually move away from that model and we are operating at no fee. So any clients that we see at the clinic, we do not charge them anything as a way to really support folks' high-need mental health needs that they need to be seeing at the clinic. The other component of the training clinic is it is a training clinic, which means all of our clinicians are students in our program who are trying to get their master's in counseling or are working towards their PhD to become psychologists. And so as part of that, we do have we work with client and that first initial phone call to the clinic to really inform them about what does that mean for our clinician to receive supervision from a licensed psychologist such as myself or other licensed psychologists we have at the clinic. That means that all of their sessions are recorded for supervision purposes where our student clinicians are able to rewatch their session, work with their supervisor to make sure that they're providing the care that the clients really need. And so that's part of our twofold mission is to really provide good training for our student and at the same time really meets the needs of our community member as well. And then, so in terms of staff, we are actually relatively small clinic. There is myself as the director of the clinic, and then outside of that, we have two very part-time, so 20% licensed psychologist or adjunct supervisor that comes to the clinic 1 day a week to help us provide supervision and oversight of all the clinical work that are happening at the clinic. And then outside of that, we have two project assistants, and Natalie is one of our project assistants this year. And so our project assistants help us with a lot of the admin work, right? They do all the triage call for us, those initial phone call, those emailing with clients or prospective client. They really help behind the scene to make sure from the moment someone contacts our clinic to then getting scheduled and meeting with a clinician. And then outside of that, we have our two community support specialists, Chi and Asita, in those roles this year. And that is really funding through the University Health Services, UHS, and MHS that really provide the funding for them to be at the clinic and serving DDEA students. And then outside of that is other doctoral master students who happens to be at the clinic or need to be at the clinic for training. And so that ranges from every year from 8 to 10 graduate students. And so because we're a small staff, I also teach in the department, and so we have pretty limited hour. We open between 3 to 4 days a week, between 4 to 5 hours each day that we're open. So sometimes I know that becomes a barrier, and we can answer more questions about that for students of that we're not open sort of 7 days a week or 5 days a week to really meet their needs. And so we really have to work with our community partnership to make sure that those students are getting services elsewhere when they need it, when our clinic is not in session. And then outside of that, we also have front desk volunteer, both graduate students in our program as well as advanced undergraduate students who are interested in going into the field. They are able to volunteer at the front desk, help us check in client and check out client as part of that. And so we work with a lot of students, and we see lots of students. We will have a slide to kind of show how many students we see, what are the number of services hours that we provide each year.
So our clinic is housed at the Educational Science Building on the 3rd floor, and we provide long-term and free and no limited sessions for clients. So the range of concerns that we're working with can be from like anxiety, depression symptoms, managing, and also processing trauma and grief. We also collaborate with McBurney and other services on campus to provide a more holistic and well-rounded support for our students as well. And so for our model of care at the clinic, we have weekly or bi-weekly sessions depending on the students' concerns and also on our availability of the clinicians. For the training aspect of the clinic, we do provide live observation and recorded sessions. So for other clinicians and supervisors to provide feedback for our students in training, so like therapists in training. We also practice cultural humility. So cultural humility is a practice, like a deliberate and intentional practice of the willingness to learn about oneself, cultural background, and others. So it's a value that is research-based, that if therapy are more likely to be effective, is tailored to the client's cultural background. So therefore, like, this is a value that we teach and practice at the clinic. We infuse clients' identity and worldview and their cultural backgrounds and practices and traditions to our therapy. To better support our clients, we also use outcome monitoring. So before the client enter the session and after they leave the session, they will fill out surveys to administer like their hope, loneliness, and other factors that might be influencing or assessing the therapeutic relationship as well. And lastly is advocacy. So we strive to empower our clients and also work collaboratively with other services on campus to connect them to resources and supports outside of the clinic as well.
Yeah, so this is all really important because we are seeing more and more people reporting things that are wrong. And so here we can see that over the years, we've had more and more students report, especially with depression and anxiety symptoms. Just like there is an increased mental health need. And we know also that even though maybe more people are reporting it, over half of these people are not receiving services, which is something we really need to address in order to be able to support students better. And so that's partially why the role exists, is to support us with that. And yeah, underrepresented students especially who are facing these unique challenges and barriers, which are contributing then to these higher rates of mental health issues. They're less likely to seek help, unfortunately, and this isn't always on the student. Typically, the situations and spaces that they are in are also not supporting them. Sorry. And so systemic methods to address the mental health needs of students have historically been underdeveloped compared to other services, and so that's partially also why the role targets that especially.
So as Natalie already mentioned, part of the reason why, I think part of showing the statistic is to really say that's part of why the program or the partnership started 10 years ago. So this is our 11th year that we'll go into this partnership. And it's really trying to address the need of underrepresented student. I think what we're also hearing is that student wants to work with a clinician who understand their lived experience, has sort of culturally, racially, ethnic identity matching in a way that they feel like they don't need to have to retell their story every single time they're meeting with their clinician. And so that's part of how this program started. And so who gets selected, or how do we really select folks to be in this role, is usually advanced student in the counseling psychology program who have gotten a year or two clinical training under their belt before they come back into this role at the clinic. And they are funded. And when we first started this program, the first few years, or the first, year 1 to 4, the funding really came directly from the DDEA program to provide service, to provide funding for the student to be able to be at the clinic 20 hours a week to serve the student. And since then, that has moved. The funding has moved to, the School of Ed picked it up for a year or so there, and then now it sits with MHS, or mental health services, in terms of where the funding comes from. And so essentially, they provide direct one-on-one counseling services to any DDEA student. I think we are their first point of contact if they're looking for mental health services on campus, where they will refer directly to us. We'll work with our PAs or our project assistant to get them into our system, and then we schedule them right away with our community support specialists. And then we have tried different model over the year in terms of when the demand is very high and we are running out of sort of capacity, then we have tried moving from weekly session to bi-weekly, but I think the goal of it is that we want to really be able to meet these students' needs on a more regular basis. So that has been the model that we have operated. And then outside of that, the community support specialist also engages in outreach, where they come into the various program and tailor workshop specifically to a group or to a subgroup within the program as well. And so again, this is just the history of where we have been. We started off in year 1 with just one community support specialist really working with the first wave program. And then we expanded that to 2 community support specialists. And so we're in our 11th year, and we're hoping for this partnership to continue, because I think what the research has shown, or the data that we have seen, is that this has been very beneficial to the student who have been able to access this care. So this is just another picture of all of the folks who have served in this role, sort of the legacy that they have really helped us to build and maintain this program over the year. And so I think this is just another slide to kind of show how many people we actually see on a year. Like if you think about with just 2 providers, or sometime when the community support specialists, they're at capacity, then some of the other student clinician at the clinic takes on DDEA student in that sense. And so if you look at from year 1 to where we were last year, we have actually, I think went up by percentage over 100% in terms of the number of clients that we're able to see, as well as the number of hours of services that we provided to students in those within a 1-year model.
Yeah, and I think something that we really stress at our clinic is centering client voices. So I know it's probably harder for us to be up here talking because we're so used to listening and holding space, but we wanted to highlight just impacts folks have shared with us over the years. Obviously, some of this is de-identified because confidentiality is really important to us, but just hearing how clients have been impacted by the CPTC and the community support specialist role. One person said, I found it helpful as like a first generation young black woman. There weren't a lot of people who could empathize with me, and there were only people who could sympathize or try to, and it just was like, okay, this is no longer useful for me. But when I was at the CPTC, it was a really enjoyable time, like getting to know myself and my triggers. Another person shared, I just assumed that all counseling was super expensive, but I do remember that, like, specifically in my scholarship program, the CPTC was kind of advertised as like a especially targeted folks for people with marginalized backgrounds, whether that be racial or ethnic minorities or LGBTQ or also first-generation college students. And I think that was helpful for me as well, just knowing that I was a part of like the mission. I won't read every quote, but what we kind of see is folks feel seen, especially by like our culture forward approach. And then this our perspective, I mean, we have 3 past and current community support specialists up here, but we reached out to some folks who've been in the role years and years ago to share like how are you impacted by the role, especially now that you're done and maybe have your PhD and practicing now. Someone shared, it was a very impactful training experience to be a clinician of color, working with clients of color at a PWI in a long-term therapy model that allowed the work to deepen based on the stability of our therapeutic relationship. Someone else shared that the work can actually be especially challenging when racially charged campus events occurred during the 2020 presidential election and the COVID-19 pandemic during the 2020 academic year. And lastly, someone shared, this role was personally meaningful as shared identities and experiences challenged me to consider what ethical and radical care looks like within larger systems. So we see that a big part of the role is sitting with like who we are, our positionalities and social location, and how that impacts why we come to the role, but also how we're impacted by it too, and the role of like environmental factors also impacting us throughout the role. And then this is our last slide before we get to more conversational stuff. But it's really important for us to highlight mental health resources on campus, whether we need them ourselves or we find students we work with need them. I think something cool about UW is there's lots of places to get mental health care. I feel like it will never be enough, but there's multiple places people can go to receive care they might need. So we just want to highlight that on the slide.
Okay, we'll transition to our dialogue here and questions and answers. So I think there will be microphone floating around if folks has questions. I think for the 3 community support specialists or even questions for myself in terms of this model. I think this is one model that I think we're, as an example, of how we can start to address mental health need for underrepresented students on PWI campuses. But we're happy to sort of answer any questions about our role here or this model more specifically.
Hello. My name is Adam. Thank you for your presentation. I didn't know anything about your organization prior to this. I work for DDEA. And I was just reflecting back on when I was an undergrad as a first-gen low-income student and how stressful and anxiety-inducing just navigating the medical system and insurance and stuff like that can be, and the need for counseling or workshopping along that. And I was wondering if you guys spend any of your time doing that or see much need for that. You just showed how many resources we do have, and so I'm sure things have gotten a lot better, but I think for our communities that it could be a particularly important subject matter. So anything you can expand on that?
I mean, I think one thing that the project assistant we spend a lot of time talking about is really thinking about like what resources are available in our community, whether that's on campus here or off campus. Part of it is we know we're a small clinic, and so we're not going to be able to meet like everyone who walks through our door. The other thing, right, to be able to practice ethically as a supervisor, there are areas of expertise that I'm not an expert in, right? So if clients are coming in and like, this is what I'm really needing or wanting, like we may not be able to meet that. So I think that is conversation we do have with clients or prospective students if they're looking for services at our clinic, and those initial phone calls that the PA have with the students really to assess what are you really looking for, are we the best fit for you? And when we're not the best fit, how do we help you access that? So we work very closely with MHS and with their access team to say, hey, we have a student who, one, maybe MHS might be a better service for them, right? They have more wraparound care, they have access to psychiatrists in a way that we don't have direct access to, that might be the better fit. And when they're not the best fit either, let's say the student more long-term outside of the university care and they have access to healthcare, then their access team actually does a very good job with helping students to navigate that. They recently just started a My Resource, and so we're part of that where the student could actually just log in and like search by demographics, search by sort of, I think even maybe clinician preferences that the students could like see who match all those different criteria and reach directly out to those folks. And I completed for our clinic here, and I think there's even, as a provider, to be able to say, I am taking clients right now, right, for a student who really wants to get in right away. So that is one thing that we're trying to help the student navigate around that too. So I hear that.
And just to add to that really quick too, I think a big part of it is also like empowering students to like learn how to figure out the system. I think we don't talk about how to like make doctor's appointments or like how students can access UHS doctor's appointments for free most of the time for like a checkup. And I think something I'll ask clients is like, when's the last time you met with a provider? If it's been a while, like why? Is it like a issue of I'm afraid of how they might treat me based off how I look or something like that? And then what can we do to support them through that? Also, is it like I don't know how to use health insurance? Like how can we empower them to get the knowledge they might need to advocate for themselves too, since we know like healthcare is a lifelong battle. Yeah.
Yeah, and I would say too that also learning how to talk about what it is that they need and dealing with. I think sometimes that is part of the work is like spending time together, really figuring out like how am I going to talk about this when I'm not just talking to you about it, or especially as we near maybe like ending our like relationship together, like what will it look like to seek services elsewhere? So that feels important too.
I guess I'm speaking as like from a therapist role, and how do we help our clients or our students navigate these challenges on campus as well. So when we thinking about like mental health, we don't just talk about mental health or psychology with the students that are sitting in front of us. There's also a challenge for us to have to think beyond the therapy room and be knowledgeable what kind of resources that is available on the community, on our campus community. And so we're not existing as a singular solo clinic on campus. We are working in a community of care to provide this care and support for our students as well. So that's an extra challenge and work that the therapist has to do when we're working with students as well.
We do have 2 questions that came in online here, so we'll start off with the first one. What are specific cultural practices that you found have benefited students as a collective or with a focus on a particular identity? You want me to read it again?
I think something that comes to mind, maybe I'm thinking about language and culture. I think with some clients in which we both speak maybe like Spanish and English, like it's been helpful to welcome that into the space and be able to explore in whatever feels easier and more comfortable, like what it is that they might need, or how they might remember certain things. And I think we've welcomed with different clients that I can remember from my experience, welcomed in talking about spirituality or different strengths that they have seen in their family members or their communities that maybe don't get talked about in other spaces. So in some ways, just even inviting that in can be really, can just invite parts of them that they haven't been able to speak to in classrooms or in other peer circles. So I feel like that has felt meaningful.
Yeah, I think something that's coming to mind for me is tapping into how have we been socialized to navigate these spaces, and what parts of ourselves do we feel like we have to suppress to be here at school, and how can we reclaim parts of our identities that felt really important to us before we got here. I think there's a method, there's so many frameworks, not enough, but there's a framework called like cultural wealth, where we kind of like reground ourselves and like, you know, as a student here, I feel like I have to figure out things by myself. I don't feel like I'm able to like connect with other people, and then recentering that as like you really value communalism and you grew up in a space where like working together was really important, and now you're here, you feel like you have to be by yourself. How can we reclaim some of that community building that was so central to how you and your ancestors survived for so long, as a means to kind of resist pressures to be something else on campus is one idea. Also thinking about building something called critical consciousness. So how are we aware of environmental factors that might make us feel like we don't belong in these spaces, and how can we empower our students and like maybe name systems of oppression that may be impacting them, so it's not always internalizing it as something's wrong with me, but something is wrong with the system that is making me feel like I'm inadequate. So ways to like repower and empower them to recognize how their identities do come with strength in these spaces, as a means to also uplift their mental health and well-being too.
I think from my culture, we're talking about, so I think in Western psychology, we're talking about psychology as like a body versus the mind, the duality of body versus mind. But from my culture, body-mind is a singular thing that is interconnected. So in my practice, like we try to use a lot of body sensory motor practices, so like mindfulness or spirituality or in the forms of prayers to raise awareness about the emotional experience that we have or we're holding in our body and express that. And talk therapy can be limited in certain way because the only way we can talk about it's using language, using the English language to talk about our emotions, but inviting like the cultural identities of the client into the space, meaning that allowing them to talk about maybe their feelings, their sensation, their imagery, their memories in their own language. And also it might also mean that there are a myriad of ways that they can express their emotional expression, and that doesn't mean talk therapy or talking. So it could be singing, it could be dancing, it could be screaming in a very therapeutic way, or moving your bodies in a cathartic way as well.
While she makes her way around, I'll go ahead and share a few comments that we have online. Thank you very much for your presentation and all the important work you are doing. Another one says, thank you for your presentation. And we do just have a few questions on top of those, but we'll go ahead and let this one go, and then we'll add to that.
Hopefully this is a short one. Do you mainly provide individual sessions or group sessions as well?
So the modality we have, mainly individual sessions right now. We do have group, and group is really, I think depending on the needs of the clients, right? If we're seeing that there's a need among, or a common threat that we're starting to notice among the clients that we're seeing that semester, sometimes that will prompt us to say, okay, we want to offer a group to, for that specific need. And the other time it's really based on the student clinician at the clinic of like, oh, I'm really interested in this very specific topic. So this past year, we ran a men's group at the clinic. And so I think that's really driven by what do we see as a need in the community, but as well as for the expertise or interest of our student clinician. But most of our therapy are individual.
All right. Are you able to address if and how you would work with international students? Also, are there things that campus partners could do to support you in your work?
I feel like we all like work with international students, and I think how it's done depends on like the clinician and like their theory and how they work with clients in general. But I think something that we might all agree on is centering like the experience of the student. What are they coming up on to us with? How are they feeling navigating campus? How is it maybe being away from home, etc.? What ways around mental health and wellness were they taught? Like what parts of that feels missing with how like being on campus have been thus far, especially in like westernized spaces, white spaces too. and starting with there to get to know, like, it's almost like a cultural exchange in a way of like, what are you bringing in with, what are your ways of knowing, and how can we meet you where you're at to help support you through this journey. I don't know if folks would add anything else.
Yeah, I guess we're leading with the value that we practice and teach at the CPTC, which is the culture of humility. So international students are the most underserved population on college campus, and we don't really see them in therapy for a myriad of reasons. It could be the cost, or there's a lot of stigma within the culture about talking about mental health or seeking mental health needs. Or it could be that they're trying their hardest and cannot find a culturally responsive clinician to work with their needs. So I guess like how Campus Partner could support bridging this gap between like welcoming or educating about mental health resources is outreach. Because most of the time, the people that would be the first people to hear about a student's mental health needs are not therapists. It could be their friends, their peer network, their advisors, their professors, their TAs. So mental health work also it's like any health or like supporting anyone. It takes a community, it takes a village. So I feel like I really strongly like believe in the power of outreach and being in the community and talking about mental health and educating people about mental health, the language to talk about mental health, the needs of mental health, and that's where like we're making the bridge between like students in the community and the therapy room and the access to the resources that they need.
Hi, thank you so much for sharing your knowledge. I have a question, hoping to learn more from you all too. You mentioned a cultural wealth framework. I was curious if there's any other frameworks that you all find particularly helpful or insightful in working with your students.
I feel like one that I think we all really enjoy is the radical healing framework. It's this framework that acknowledges histories, building critical consciousness. There's 3 other points of like factors that goes into it, but it's basically how can we get into this medium of like wanting things to change and be better in society while also taking care of us, and how making changes is also coming with strengths internally and communally too. But how do we do it in a way that doesn't like burn us out and make us always feel that sense of dread? How do we also have hope while we're doing this work too for ourselves and for folks we love? And I think a lot of clients, sometimes I'll even bring the framework into the room and talk about it, feel empowered to know that folks are thinking and centering their communities and ways that environmental factors impact them in like mental health work too.
And I would add too that it's helpful sometimes for us to just think about something that's bigger than us, and so many of the spaces we're in can isolate us and like maybe make us feel like we're the only ones experiencing this or no one understands. And so sometimes with these frameworks, it can help us like connect with our ancestors or connect with like our communities in ways that even though they're not maybe physically here, they might be like present in the room with us, or in different actions that people take. So just going off of that too.
So we have one wondering, do you usually see more students or community members? With that in mind, do you also provide career counseling, and what does that look like?
So I would say it used to be where about 70% of our clients are community member and 30% are college students. Since the partnership, that have flipped for us. So about 70% of our clients are students and about 30 are community member. And some of the community member, I would say, I think it's based on some of the different initiatives that faculty in our department are also working in collaboration in communities. So we get lots of different clients who are coming to the clinic for gender-affirming care letters, for surgery, some of those different things, but that's really initiated by other faculty in the department and the partnership they have in the community for those clients to also be aware of us and they come to the clinic for some of those different resources.
Thank you. This has been great. I have 2 questions. First, I'm wondering if you all do like neuropsych evaluation kind of work at all? Because I feel like that's something that, students come to college and they might realize, oh gosh, I think I might have ADHD or autism or what have you, and it's really hard to get on a list, and it's really expensive to get a diagnosis, and most of the students I work with are students who couldn't afford to pay out of pocket for that kind of thing. So I'm curious what you do in that realm. And then my second question is, could you all just share some of the themes that you're hearing from clients? I know obviously you can't speak about specifics, but just what are the things that are on students' minds that are helpful to us to all know about, to be aware of, so that to realize it's normal what they're going through.
And maybe let me answer the second part of that previous question. I completely was like, what else was that question asking? About career counseling, right? So we do, I think part of it is our philosophy of really seeing career counseling as really embedded into the personal counseling. So we don't do like, here's a career counseling appointment that you come in and you really just talk about career. We actually really fold it into the way that we really think about the whole person and the wellness of the student in regards to what their academic need might be, the academic stressor. I think knowing that 70% of our clients are students, we are always sort of center their identity as a student at the forefront, and how that also impact some of the different distress that we are seeing at the clinic. And so in some way we do career counseling, but maybe not in the traditional way that I think other people think about. I go in for like 3 sessions to talk about a specific career concern, but we sort of really fold it and integrate it in and do that.
You said, do we do neuropsych evaluations, and then what are themes that we're seeing across students? We don't do neuropsych evaluations, and I think that's just a big gap in the field of how inaccessible those things are to get, and how it's tied to maybe being able to access like medication and other things. But I think something that we can do is affirm maybe clients' experiences, recognizing maybe something is off that hasn't been noticed and hasn't been accommodated for, and connecting them with like McBurney services on campus, which provides accommodations for students who have various symptoms, and you don't always need like an official diagnosis to get those accommodations too, which is helpful. But I think that's a big gap in the field of how inaccessible it is.
And I think seeing the clients that we've been seeing for the last few years or the last decade, in some way, I do agree with you that there's a huge need, I think, to get some of those different assessments done. And I think it's really speaking to that point about how expensive those assessment could be. Maybe this is a plug, I think, for DDEA, or I think for all of us to really think about how do we also, I don't know whether that's like setting aside money, emergency fund, or sort of assessment fund, right, for students to be able to access that. Because I do think that there is a huge need, and unfortunately we don't provide that at the clinic. But, I think the PRTC, so the psychology training clinic, Natalie can talk a little bit about that as you're like, I think, working there this semester too. There are resources on campus that are accessible to students, but helping them to get connected, and there's no fee associated with that for students who may be not able to afford those fees. So how do we as a community come together to really support those students who really needs it?
Yeah, and I would add that oftentimes, I think, to clarify too, like an evaluation can help someone then get like medication or access other services that they may not be able to get without that. So there is only so much that we can do before they still reach another barrier. And so I think that feels important to consider. And yeah, the Psychology Research Training Clinic is another place on campus where there are lower fees, but there are still fees, and I think that can still be pretty, yeah. Right, yeah, it can be, I think the lowest is like $300. But there are payment plans and things like that, but either way, just to get like students past that, it can be really hard.
And I would say, I think part of some of the fee, I don't do assessments, so I can't really speak from a personal experience in this, but at least practicing in the field. I think just administering just the test alone itself, there's like fee associated with that, right? So even if we're thinking about not charging fee at all for sort of that services that the clinician is like interpreting the report, I think to be able to just test that, like give them that fee and score it, there's already fee associated with that. So I think that's where that high piece comes in. But maybe more advocacy around that would be really helpful. Mm-hmm.
Yeah, great panel. Thanks very much. So you know, this work is critical, and it wasn't around when I was, you know, an Indigenous undergraduate student. So, you know, I had the sink or swim thing. Lots of students, friends of mine that, you know, didn't make it through the university experience as a result of the suffering and silence that went on. So this is critical, and I loved what you had to say about attaching this, you know, to the whole body. Mm-hmm. This work is, you know, as critical as, you know, the rec centers on campus. So students, when they come for SOAR, you know, all these buildings will get shown off. But is your center a part of SOAR? Like, do students get this from day one, that they know that there are these resources available, so that if they ever have to call back on them, you know, don't just go run it off at at the NIC or whatever, but you might need to talk to somebody. How does SOAR play into including you in their, you know, menu of resources for students, I guess is what I was wanting to ask.
Yeah, we don't get plugged into SOAR as part of their resource table, or I think as part of the resources that maybe they promote, advertise. I think part of it is, yeah, maybe that's a connection that we need to also really think about, how to build those relationship partnership with SOAR, and really getting students to hear about our clinic and to see us as a resource on campus. Oftentimes, I think students hear from us. I think with the partnership with the DDA student, we do a lot of outreach. I think we directly work with a lot of staff and faculty within the program, and so they are aware of us, and I think students know us by that. We also do a lot of like outreach and engagement with the student, but I think SOAR is another maybe great avenue for us to consider for future partnership.
Yeah. Just a point of clarification, does your office provide family or couples counseling? And as a training center, how do you provide care during winter and summer breaks?
Great question. So the services we provide for family, we have provided couples and family in the past, and that really depends on who is the licensed psychologist on staff. Unfortunately, that's not an area of expertise for me right now, so we don't have that, but our previous director does have expertise in couples, so we have provided couples counseling in the past under her license and supervision. We have had previous licensed psychologists at the clinic that had expertise with working with children and families, so we have done that. So we're in the process of hopefully we'll be able to hire more folks to join our department. So hopefully they will bring in their expertise. I'm very excited about meeting some of the candidates that has come through already, that they will also be able to add that sort of range of services that we can offer at the clinic. And because we are a training clinic, we do not provide services over winter break. Our student clinician needs a break themselves. And so unfortunately, so that is something that we take into consideration when we're thinking about best fit for a clinic. Is this a client who's going to need ongoing care over winter break as well as during summer break? Is this someone who could pause when we are on pause? And so I think those are things that we do take into consideration. Summer at the clinic has changed over the year. For the past few years, we do have summer clinic is open, but we're only open one day of the week. And we have fewer clinician clinics based on volunteer students who want to be around or who are around in the summer. So we have very limited staff for that reason. So again, I think we want to provide more services. I think it's just really thinking about the care for our student clinician as well.
Hello. I have less of a question and more of like an add-on to what you all have been talking about. I'm actually a clinician over at UHS at Mental Health Services, so thank you for the work you do. We really appreciate you, and I also refer to you a lot. So just to add on to some of the like points I've been hearing today, so I think one thing that hasn't been managed that might be, not managed, mentioned, is care management is something that UHS offers through mental health services. So that kind of goes to that first question we had about like, what do we do for students who maybe aren't a fit for like either of our agencies or maybe like need that long-term care? Yeah, care management is great because like it addresses like what insurance do I have? Do I know how to use the insurance card? What do I do if I don't want to talk to my parents about using insurance? Also for those assessment services questions. So at UHS, yes, like testing fees are ridiculous. And so Also because we're like a counseling center at UHS and not like a testing center per se, that's why we can't offer those like formal batteries, just because it does take a lot of time and training. But we have great care managers who do different types of care management appointments, so they can help students kind of figure out like where in the community can you go, is there like a payment plan that you can do. Also McBurney offers great services for like student support groups. We have workshops for ADHD skill management, student success workshops. So there's a lot of like elements of things that we can offer to help students in the meantime while they're waiting to get that testing done. And then also couples counseling, we do offer that at UHS, and only one person in the couple has to be a student. So both people in the partnership have to do like an access appointment to get signed up with our services, but they can see us for couples counseling. So basically, if you ever have a question about something and these lovely folks can't help you, please volleyball to us because we can probably answer a question and provide a referral in some way too. So I just wanted to add on to what you all were saying. Thank you.
One wondered if your office considered parenting students as underrepresented student populations.
Not according to maybe our definition of it, but we do, I think we do work with students who are parenting. So I think those are not issues that we shy away from, but in some way, I don't know if I think we follow the sort of federal definition of what is underrepresented student in that sense. Yeah.
Thank you.
I just want to have a quick clarification. So I know that you've mentioned the division quite a bit, but does a student have to be part of the division in order to?
They don't. I think we mentioned it because the partnership that the DDA community support specialists, they can only work with students within the division. But our other clinicians who are not in this role can see anyone. So those are oftentimes what the community clients do see our other student clinician.
Thank you for the work you do. I may have missed this, but are you interested in growing? I heard you mention interviewing someone. And what, as a community, can we do to support your growth?
Short answer is yes. I am very interested in growing. My capacity as a one staff shop right now really limits that for what the growth could look like. So I guess I think more partnerships like this, I think allow for, I think one thing that I didn't mention in the partnership is that because of the partnership with MHS, we do have one staff from MHS that comes over to the clinic one day a week that provides supervision for that shift. And so I think that does free me up differently. So I think that whether if there's interest to sort of develop more partnership with our clinic to then really be able to bring in student clinician. The first year doc students are required to be at the clinic, so they will be there as clinician. But for many of our students, their clinical works are not paid, right? And so I think it's a real privilege for folks to be in this role that they do get paid as an assistantship to see client and count as clinical work. Otherwise, they have to hold another 50% sort of assistantship as well as be at the clinic, which sort of really taxing. So I think some of that additional resources and funding to really provide more role would be really helpful.
A comment here. Thank you for all your excellent work and your presentations today. And following up with a question, have you ever hosted any programs or workshops that are open to all students? And are you open to collaborating with campus units for upcoming workshops?
I think most of the workshops that we have done have been to specific offices if they're looking for a workshop and have reached out to us directly. We have done some outreach, like campus-wide outreach. I think you all were at one this recently. Maybe we can talk a little bit about that. I think we are open to collaborating. I think, again, it's really being thoughtful about, balancing, I think, for our student of the number of one-on-one appointment that they do have with their client, and then outside of that, how much time they do. So because we're relatively small staff, we want that collaboration. It just might be hard to sort of be able to meet all of that demand at this point. But we welcome them if they're interested in wanting to collaborate. I'd absolutely reach out to us, and we can kind of figure out a way.
Yeah, I think something that we do, like Chi and I and what Nat has done in the past, is in the beginning of the summertime, we'll email all the DDEA like staff and like faculty a part of those programs and let them know like who we are, our role, and that we offer outreach and workshops. If they fill out like a Google form, we'll put something together for them. And how that process works is they'll fill out the form and they'll put like broadly what they're hoping to get, and then we'll meet with them one-on-one to let them know the students, what the students may be struggling with, kind of like who they are. And then Chi and I will like sit down and creatively think about how can we create an engaging workshop for this group that they can like take something from it and also feel welcome to share maybe more vulnerable experiences. And then we always offer like our services and how to get in contact with us or other units on campus too, if they do choose to do that. We haven't gotten as many outside of DDEA workshops, which is because our role is funded to work exclusively with DDEA students. That's who we kind of focus on. But I don't think we'd be opposed to that. I know we did the all-campus like mental health day that UHS held, and we talked to lots of students, and some like people can connect with us even if they're not DDEA students too. But that's kind of how our outreach and workshops work as of now. But that can always, I don't know, change and be adjusted.
The mic's coming.
Themes we see.
The themes, right? I was gonna have this, themes that you've been seeing with your clients, not using identifying information.
I could start us off. I'm sure we all come across different things that will also hit us differently, but I think something that comes to mind is like many of our students maybe receive messages about what it means to be successful from their families and from society and from like classrooms, like just from everyone, and sometimes those can be really conflicting, and it's just really hard for them to know like how can like success not come at a cost to my own well-being. And so I've noticed that sometimes the work is sort of like acknowledging how important like your wellness is not like less important than that success, and like even the idea of success, like Nasita had mentioned critical consciousness and things like that, like really contextualizing what it means to succeed. And yeah, I think that feels like a really big theme, that and then the different challenges it might have can vary, but I think that's oftentimes a thread. Mm-hmm.
Yeah, I think something that I'm holding to is just with the age range that we tend to work with. A lot of times, this is the first time. I always say college can be really exciting for lots of reasons, but this is also the first time some folks might be experiencing like depression or anxiety in ways that they haven't before. And I think I see that coming up, I guess, a lot in the work.
I think some of the predominant like emotions or things that we're sitting with is like grief or pain or struggles, the loneliness and depression and anxiety. In the culture of over-involvement and high achieving. So they also, like Natalie just said, this cultural message about what it means to be successful, what it means to be doing well, and this like impossible expectation to always be happy, healthy, and successful. And that also come at the cost of like sacrificing our own health and social, emotional well-being as well. And another themes that we've been seeing, and also we would try to tailor our workshop specifically to that need, is like the lack of belonging on campus. That especially apply to students who are identified with students of colors or low-income students, first-generational college students as well. They perceive like a lack of belonging in the campus community. So we would tailor a workshop to talk about like what would belonging feels like, look like, what is your story about belonging, and how do we find space to find that belongingness to support you through college as well.
Yeah, I will also just echo maybe what she was saying about I mean, I think our students are so resilient, but underneath all of that, they carry so much, right? They're so packed in terms of the pain, the experiences, the struggles that many of them are holding, and many of them don't talk to anyone about this, that they feel like they have to do it on their own. And I think even coming into therapy, it's very hard for them even to open up in therapy with us. And so I do think that there is a lot that all of our students are walking around each and every single day, and sometimes be in the context of this university, a predominantly white institution, also add on to that for them. I also think, I mean, we also see sometimes students are all on social media. And so sometimes you see themes of like, they're like, oh, I saw this thing. And then they're coming in and like talking to you using like clinical language in a way that maybe they don't always fully understand, or that the information maybe is a little off or not always like accurate in that way. So I think we have to do a lot of work about what is it that they're also taking in. I think from social media, some of the social medias are amazing and right, really positive, this notion of self-resilience and strength and all of that, and absolutely, and other time that reinforces that they also then can't seek out help and support. So we do see some of that themes as well.
I feel like yes. I'm just trying to think.
I'm like, what happened in class?
I mean, I think maybe one thing is, I think like being in the room and sitting with like someone's pain or hopelessness can be like, I think that can just like be kind of jarring sometimes, or like and joining. Oh, sorry. I think sometimes just the emotional experience of being in the room with someone, I think that feels different than whatever we read about or were taught about sometimes, and just then what that means for us to take care of ourselves. I think that can evolve over time too, the more like practice we get. Yeah.
I think something I'm holding is, I think sometimes we learn about like theories broadly, like what's the evidence behind doing X, Y, Z thing? What's the evidence behind treating something like depression and anxiety? And I think something I've learned in like supervision, which like we all get to talk to folks who are licensed and our peers too about how we're feeling about the work in other spaces as well, is how important, like you can like know a theory so well, but if you can't do it authentically and like honestly, like the care we have for our clients, like if our clients feel that and like really believe that, that can lead to so much change too. Like having someone who like is holding space for you and wants to like be there through like your most vulnerable experiences is really strong. And while the evidence is important, but just being able to approach the work with humanity first is something that I often sit with, where I don't know if we like teach that, but it's just something that we hold of like, how can I be my authentic self and hold the knowledge I've learned in classes to do the work well too. Just how much of me shows up in the room has been like more surprising when I was a beginning clinician of like, wow, I have to like be myself to be effective. I thought I had to like pretend to be a therapist, but the best part is being me in the space too.
Yeah, I'm also sitting with like my education about theory as well. So counseling theory are like a different ways we think about where suffering come from and how do we how people change or how people heal their suffering. And so a lot of those theory are coming from or applied on people who are white, upper middle class, and westernized lens of psychology. So when we applying those theory as like in like a cookie cutter attitude, like a lot of clients don't feel like that's effective for them, or that's like they don't feel seen through this like lens of theory that we're using. So a lot of the learning that we're doing happen when we're doing the work, when we are learning from communities, and when we are self-reflecting on our own cultural backgrounds and beliefs and values that we carry into practices. So even though like counseling theory might or might not be helpful or not helpful for some people, a lot of the therapeutic effects that is evidence-based originated from indigenous community practices and like Asian spirituality as well. So we're really trying to like bridging that, like doing a lot of our own learning into this like therapeutic practices so we can incorporate it into our practice as well that is congruent with our values or how we see people and understand their suffering and pain.
We are at 2:35. I believe we have one question in the back of the room. You still have a question? No? Yeah. Thank you. I can repeat it for you if you'd like.
Oh, maybe this isn't an issue at all, but I was wondering, as I know you're funded through UHS now, but you were through DDEA originally, and a lot of our focus is always on academic performance and getting students to graduate in a certain amount of time and with a certain GPA. And is there ever any tension there between your goals and objectives, which should ideally be the patients, where it's not necessarily academic focus, or it shouldn't be academic focus, whereas it should be on their well-being? And I'm just wondering, as a university resource, if there's a tension there at all.
I mean, I think that is something we think about, right? Really trying to think about how do we get student to, I mean, the student also has the same goal, right? They're like, I came here, I want to graduate on time. We hear a lot of student talks about sort of the financial stress of not being able to graduate on time, and if that's gonna, like they had to figure out how to pay that out of pocket. I think, so we do think about it. Do we always put that at the forefront and center of our work? I would probably say no. I think part of it is really what the student brings in. And sometimes I think there have been times where I think part of the work with the student is how do they learn to, whether to take a semester off, right? If there's so much pressure, if this is not the right environment for them, how do we really center their well-being in that sense, and really work with them from that perspective? Sometimes I talk to students about taking a semester off. You might be able to come back at a faster rate when you have been able to really address what your needs are right now versus continue to push through at this moment in time. And so I think we really try to work with the student to still get them to that goal, even if maybe not within that 4-year time frame. And also I think in some way, largely, I will also say that sometimes that message is about that you need to finish within this time frame has also done some harm, and I think that's really hurt the student in some way too. And so I think we try to really balance both of those perspectives, the need from the university or the funding to say we have to graduate these students in time, and at the same time really centering the well-being of the student. All right, I think we're at time, so we appreciate you all being here and like listening to our talk and engaging in this dialogue with us. And if you have any questions, feel free to come up to us after today, but we appreciate you showing up.
And just to quickly acknowledge the last comment that just came in, to piggyback on the last question, Chi, they wanted to thank you for naming that and calling those comments out.
And as you all wrap up, can you also fill out the evaluation for the group as well? So the QR code is up on the screen too. I'm sure our presenters would value your feedback as well. Thank you.